Okay, so for lung cancers, you're going to have to know what metastasizes to the lungs and what metastasizes from the lungs. First off, metastasis to the lungs, usually going to be more multiple lesions, so scattered around, and it's more common than a primary neoplasm. So just think of like all of the different cancers put together. Metastasizing to the lungs is a lot more common than a primary lung cancer, which is kind of counterintuitive because of the incidence of lung cancer and smoking and so on and so forth. A common presentation for lung cancers is going to be your patient coming in with coughing up of blood. So it also can present something similar to a pulmonary embolus. So that's why you're going to go and do probably the similar labs you would for a patient who presents like they're having a pulmonary embolus. Lung cancer patients can have wheezing and a mnemonic coin lesion on chest x-ray or a non-calcified nodule on CT. So metastasis from a primary lung cancer is going to be LAB, L-A-B-B. That's going to be your lungs go to the liver, adrenals, bone, and brain. Lungs go to the liver, adrenals, bone, and brain. So if you know a patient has primary lung cancer, you're going to be wanting to somehow monitor their progression of disease. Hopefully it's not progressing quickly, but if they come in with a new diagnosis of a primary lung cancer, you're going to want to check the metastasis and for sites like the liver, adrenals, bone, and brain. So if you have a primary metastasis elsewhere, where would you commonly think that the original cancer would be if you found a metastatic tumor in the lungs? So it's going to be breast, colon, prostate, and bladder. Common complications of lung cancer are Pancoast tumor, Horner's, endocrine paraneoplasias, recurrent laryngeal nerve compression, effusions, and also superior vena cava, as well as thoracic outlet syndromes. On the top here, you can see small oat cell, which accounts for about 15% of all lung cancers, and it has a poor prognosis. This one in particular can invade the hemithorax. So one thing to remember with the ones that start with S, which there's really only two, so small and squamous. So small and squamous are central and associated with smoking and syndromes. Squamous, small, central, smoking syndromes. So small cell or small oat cell lung cancer, it's undifferentiated, which makes it quite aggressive. It's associated with that Cushing's, which is ACTH producing tumor, SIADH, antibodies like Lambert-Eaton and paraneoplastic syndromes, or also to neurons, which is your paraneoplastic myelitis, encephalitis, and subacute cerebellar degeneration, which is associated with the antibody anti-Hu, with Purkinje antibody. Patient with a small oat cell is going to have an increased amplification of LMIC. You're going to want to treat them with chemo, with or without radiation, but definitely you're going to want to give them that chemo because of the poor prognosis. Small cell, most of your small cell tumors throughout the body are going to be neuroendocrine tumors, and they're going to have an appearance that you can see on the right. This sometimes it's described as dark blue cells, or small dark blue cells. These are your Kolchinsky cells. Keywords here for histology is chromogranin A, enolase, synaptophysin. Next, we have adenocarcinoma, which is going to have an association with KRAS, EGFR, ALK. Common presentation, if you have a female coming in who's a non-smoker, maybe she has clubbing and osteoarthropy, you do imaging and she has consolidation, and say, for example, weight loss, you're going to be thinking adenocarcinoma. There is one subtype, which is called the bronchoalveolar, and that's an adenocarcinoma in situ. Essentially, it has it grows along the alveolar septae and appears as thickening of the alveolar walls. Here you'll also see tall columnar cells containing mucus. It's an adenocarcinoma, right? So it's going to have a glandular appearance, as you can see on the right. Squamous, again, squamous, small, central, smoking, and syndrome. So squamous is going to be associated with a hilar mass or central cavitation, and so the PT-HRP with the squamous, so elevation in PT-HRP is going to be what causes the elevation in calcium. Additionally, it's going to have a cavitation most likely. So I remember calcium cavitation and squamous. And all, again, on the right side, you can see I have keratin pearls and intracellular bridges. That's common to all of your squamous cells carcinomas, and the common presentation here is a male smoker, so the exact opposite as of your female non-smoker. Large cell carcinoma doesn't start with an S, so it is peripheral in nature. It's highly anaplastic, undifferentiated, has a poor prognosis, and not quite responsive to chemo. You're going to probably have to go in and remove this surgically, but it has a strong association with smoking. I always remember highly anaplastic tumor and undifferentiated. You're going to want to remember that there's an association with elevations in HCG, gynecomastia, and galactorrhea. So undifferentiated, I always think that it can be a male or female smoker, and this male or female may have elevations in HCG and galactorrhea and or gynecomastia. You can have these giant gynecomastia, giant cells, giant gynecomastia. Bronchial carcinoid tumors account for about 5% of all tumors in the primary lung tumors. Can be central or peripheral, and it's going to cause these mass effects such as flushing, diarrhea, wheezing, and salivation. It has a pretty good prognosis, and it has chromogranin A histology marker, and it's going to have these nests of neuroendocrine cells, as you can probably see in the small oat cell as well. I've also seen the bronchial carcinoid tumors described as polyp-like masses in the bronchus.